Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 200 of our Pharmacotherapy MCQ series, which majors in cardiology. And the next question reads, which of the statements below regarding targeted pulmonary arterial hypertension therapies is most accurate? Is it A. Selexipag is expected to be better tolerated than prostacyclins, or B. Iloprost is an inhaled prostacyclin given 4 times a day, or C. Oral treprostinil is an adequate replacement for parenteral prostacyclins in most patients, or is it D. Treprostinil is administered by inhaled, oral, and parenteral routes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Treprostinil is administered by inhaled, oral, and parenteral routes. Answer D is correct. Treprostinil is available in many formulations, including inhaled, oral, and parenteral. Iloprost is an inhaled prostacyclin analog but is dosed 6 to 9 times per day. That makes answer B incorrect. Oral treprostinil is not a suitable alternative to infusion prostacyclin for most patients, but rather for carefully selected and stable patients. That makes answer C incorrect. Selexipag's adverse effect profile is similar to that of prostacyclins. That makes answer A incorrect. Please advance to the next question. And the next question reads, according to the AMBITION trial results, which of the following suggested initial therapies for pulmonary arterial hypertension would best be considered? Would it be A. stepwise therapy, epoprostenol, followed by the addition of sildenafil, or B. upfront combination therapy, tadalafil, macitentan, and selexipag, or C. upfront combination therapy, tadalafil and ambrisentan, or would it be D. stepwise therapy, tadalafil, followed by the addition of ambrisentan? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. upfront combination therapy, tadalafil and ambrisentan. Answer C is correct. The AMBITION trial showed that upfront combination therapy with tadalafil and ambrisentan unequivocally improved clinical outcomes compared with either agent alone. The other medications and dose regimens listed were not studied in the AMBITION trial. Answers D, B, and A are incorrect. Please advance to the next question. And the next question reads, KOP, a 34-year-old male patient, presents to your hospital with his 3rd episode of recurrent idiopathic pericarditis. He has a past medical history significant for irritable bowel syndrome, for which he takes psyllium fiber and eluxadiolin. His current medications include ibuprofen 800 mg orally thrice daily, colchicine 0.6 mg orally once daily, and prednisone 40 mg orally once daily for the past 3 months without significantly improved symptoms. He has no known drug or food allergies. He weighs 80 kg. So my question to you is, which of the following would be the best recommendation regarding therapy for COPS pericarditis? Would it be A. Add anakinra, or B. Increase the prednisone dose, or C. Discontinue colchicine, or would it be D. Add aspirin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Add anakinra. The best choice for this patient is to add anakinra. That makes answer A correct. Anakinra is recommended in patients with recurrent pericarditis who are refractory to aspirin or non-steroidal anti-inflammatory drugs (NSAIDs), plus colchicine, and who are steroid dependent. Using a combination of aspirin and an NSAID is not recommended for pericarditis. That makes answer D incorrect. This patient already takes the maximum recommended dose of prednisone, so increasing the dose would only increase the likelihood of corticosteroid-induced adverse effects. That makes answer B incorrect. Finally, colchicine improves response to aspirin or NSAIDs in recurrent pericarditis and is recommended for up to 6 months in these patients. That makes answer C incorrect. Please progress to the next question. And the next question reads, PST, is a 16-year-old female patient who was admitted to your hospital 5 days ago because of flu-like symptoms and severe weakness, malaise, and lethargy. Her examination reveals an acute heart failure. An echo reveals a left ventricular ejection fraction, abbreviated as LVEF, of 30%. A diagnosis of viral myocarditis is made and she is placed on therapy for heart failure. PST's condition has continued to deteriorate, and she has since been placed on extracorporeal membranous oxygenation, abbreviated as ECMO, for worsening heart failure. So my question to you is, which of the therapeutic options listed below would be best to initiate for PST's refractory viral myocarditis? Would it be A. Azathioprine, or B. Methylprednisolone, or C. Cyclosporine, or would it be D. Immunoglobulin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Immunoglobulin. Azathioprine and cyclosporine are the two immunosuppressants recommended for autoimmune and other inflammatory-mediated causes of myocarditis, but they should be avoided in infectious causes of myocarditis, such as in this patient. That makes answers C and A incorrect. Corticosteroids like methylprednisolone are also recommended for autoimmune and inflammatory-mediated myocarditis but should also be avoided in infection-related myocarditis. That makes answer B incorrect. Immunoglobulin has been shown beneficial in refractory autoimmune and viral-mediated myocarditis and may also improve mortality and LVEF in these patients. Therefore, immunoglobulin is the best answer. That makes answer D correct. Please proceed to the next question. And the next question reads, YTF, a 73-year-old male patient presented to your accident and emergency department with symptoms consistent with acute ischemic stroke. He has a past medical history significant for hypertension, hyperlipidemia, type 2 diabetes mellitus, and a mechanical mitral valve replacement. His current medications include candesartan 16 mg orally once daily, rosuvastatin 10 mg at night, metformin 1000 mg orally once daily, and warfarin 7.5 mg orally once daily. His pertinent labs include an INR on admission of 3.1. A transesophageal echocardiogram revealed a 0.4 cm mobile thrombus on his mechanical valve, which was successfully treated with unfractionated heparin. So my question to you is, which of the following is the best recommendation regarding future anticoagulation therapy in YTF's clinical scenario? Is it A. warfarin plus clopidogrel, or B. warfarin with a goal INR of 4, or C. warfarin with a goal INR of 3.5, or is it D. warfarin with a goal INR of 3? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. warfarin with a goal INR of 4. For patients who have a thromboembolic event secondary to valve thrombosis while receiving adequate anticoagulation with a vitamin K antagonist, the recommendation is to increase the goal INR. Because this patient's INR was within goal range for his mechanical mitral valve at the time of his thromboembolic event, the 2014 AHA and ACC guideline for the management of patients with valvular heart disease recommends a new goal INR of 4. That makes answer B correct. Keeping his INR goal at 3 would only be appropriate if his INR was subtherapeutic at the time of the thromboembolic event. That makes answer D incorrect. There is no recommendation to only increase the goal INR to 3.5 for patients whose therapeutic vitamin K antagonist anticoagulation fails for a mechanical mitral valve. That makes answer C incorrect. Finally, adding clopidogrel or another P2Y12 receptor antagonist has not been studied in the setting of failed initial anticoagulation therapy for mechanical heart valves. That makes answer A incorrect. Please progress to the next question. And the next question reads, PID, a 49-year-old female patient presents to your cardiac clinic with a history of infective endocarditis, abbreviated as IE. So my question to you is, for which of the procedures listed below should PID receive prophylaxis for IE? Is it for A. excision of a non-infected mole, or B. surgery for a deviated septum, or C. colonoscopy for polyp removal, or is it for D. ureteroscopy for infected urolithiasis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ureteroscopy for infected urolithiasis. And I will tell you why. Current guidelines recommend prophylaxis for IE when a patient meets a qualifying cardiac condition and is undergoing a procedure with a risk of infection. In general, procedures on non-infected skin or organs do not require prophylaxis, such as colonoscopy for polyp removal, surgery for a deviated septum, and excision of a normal mole. That makes answers A to C incorrect. A patient with a history of IE would need prophylaxis for removal of an infected ureteral stone using ureteroscopy. That makes answer D correct. Please proceed to the next question. And the next question reads, SKL, is a 36-year-old male patient who is on hospital day 4 for infective endocarditis, abbreviated as IE, involving his native mitral valve and acute kidney injury. He has no known drug or food allergies. His pertinent current labs include a BUN of 67 mg per deciliter, a serum creatinine of 3.8 mg per deciliter, a WBC count of 16.1 times 10 power 3 cells per millimeter cubed with 86% neutrophils and 5% bands. His vitals include a body temperature of 38.7 degrees Celsius and he has only produced 100 milliliters of urine in the past 1 day. This morning, 4 out of 4 of his blood cultures returned positive for enterococci resistant to gentamicin. So my question to you is, which of the antimicrobial regimens listed below would be most appropriate to use in SKL's clinical scenario? Would it be A. vancomycin plus rifampin, or B. daptomycin, or C. ampicillin plus ceftriaxone, or would it be D. penicillin G plus streptomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. ampicillin plus ceftriaxone. Guideline recommended therapy for patients with IE caused by gentamicin-resistant enterococci includes therapy with either ampicillin plus ceftriaxone, or ampicillin or penicillin G plus streptomycin. Because this patient has an acute kidney injury with a low urinary output, aminoglycosides should be avoided, thus, penicillin G plus streptomycin would not be optimal. That makes answer D incorrect. Ampicillin plus ceftriaxone would be the best regimen for this patient. That makes answer C correct. Daptomycin is only indicated for patients with IE caused by enterococci resistant to penicillin, aminoglycosides, and vancomycin. That makes answer B incorrect. The combination of vancomycin and rifampin is only indicated when also combined with gentamicin for prosthetic valve IE caused by methicillin-susceptible staphylococci. That makes answer A incorrect. Please progress to the next question. And the next question reads, TWD, is a 67-year-old male patient who is being admitted for suspected infective endocarditis, abbreviated as IE. He has a chief complaint of a 1-week history of fever, chills, night sweats, and malaise. He has a past medical history significant for hypertension, COPD, coronary artery disease, and a prosthetic aortic valve placed 5 years ago. He has no known drug or food allergies. Regarding his social history, he does not smoke or drink alcohol, and he has no history of drug abuse. His pertinent labs include a normal serum electrolyte, a serum creatinine of 0.9 mg per deciliter, a BUN of 21 mg per deciliter, a WBC count of 23.1 times 10 power 3 cells per millimeter cubed with 88% neutrophils and 9% bands. His TEE shows a normally functioning aortic prosthetic valve and a mitral valve with a 0.2 cm density on the anterior leaflet that is suggestive of a vegetation. So my question to you is, which of the following would be the best empiric antimicrobial regimen to treat TWD's IE? Would it be A. vancomycin plus gentamicin, or B. ampicillin plus nafcillin plus gentamicin, or C. vancomycin alone, or would it be D. vancomycin plus gentamicin plus rifampin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. ampicillin plus nafcillin plus gentamicin. Although this patient has a prosthetic heart valve, he does not need empiric therapy aimed at treating prosthetic valve endocarditis because his valve was placed over 12 months ago. Therefore, vancomycin plus gentamicin plus rifampin would be incorrect. That makes answer D incorrect. The best regimen for this patient would be ampicillin plus nafcillin plus gentamicin. That makes answer B correct. Vancomycin alone would only be used for patients with a history of intravenous drug use or suspected right-sided endocarditis. Because this patient's echocardiogram reveals a possible vegetation on his mitral valve and he has no history of drug abuse, he would not be suspected of having right-sided infective endocarditis. That makes answer C incorrect. Vancomycin plus gentamicin is indicated for empiric therapy in patients with a severe beta-lactam allergy. Because this patient has no drug allergies, this also would not be the best option. That makes answer A incorrect. Please proceed to the next question. And the next question reads, which of the statements listed below best interprets a patient's responsiveness to clopidogrel with CYP2C19*1*2 genotype results? Is it A. Genotype provides no useful information with respect to clopidogrel response, or B. Patient has normal response to clopidogrel, or C. Patient has increased response to clopidogrel, or is it D. Patient has reduced response to clopidogrel? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Patient has reduced response to clopidogrel. Answer D is correct because the *1*2 combination would result in a reduced response to clopidogrel, given that *1 is a normal function allele but *2 is a no-function allele. Answer C is incorrect because the *2 allele is a no-function, not increased function, allele. Answer B is incorrect because although the *1 allele is a normal function allele, the *2 allele is a no-function allele. The *1 and *2 combination is expected to result in a reduced response to clopidogrel, not a normal response. Answer A is incorrect because much of the literature now supports an association between the CYP2C19 genotype and clopidogrel responsiveness. Please progress to the next question. And the next question reads, which of the statements listed below best describes the role of the Clinical Pharmacogenetics Implementation Consortium, abbreviated as CPIC guidelines in the clinical implementation of pharmacogenetics? Is it A. Provide guidance on the timing of when to order a pharmacogenetic test, or B. Provide information regarding the interpretation of pharmacogenetic test results for medications where there is literature support, or C. Provide information regarding which pharmacogenetic test should be ordered before medication prescribing, or is it D. Help determine which medications do not require pharmacogenetic testing before prescribing? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Provide information regarding the interpretation of pharmacogenetic test results for medications where there is literature support. Answer B is correct because the CPIC guidelines are developed to provide guidance on the translation and interpretation of pharmacogenetic test results when they are available for specific drug-gene pairs if evidence in the literature to support the guidance is insufficient. Answer D is incorrect because the CPIC guidelines do not include information on which medications do not require pharmacogenetic tests before prescribing. Answer C is incorrect because the CPIC guidelines do not make recommendations regarding which pharmacogenetic test to order before prescribing a medication. Answer A is incorrect because the CPIC guidelines do not provide guidance on the timing for ordering a pharmacogenetic test. Please advance to the next question. And the next question reads, KZA, a black female patient presents to your clinic for treatment. She has a past medical history significant for newly diagnosed atrial fibrillation. She was recently initiated on warfarin. You discover that she had a pharmacogenetic test and that the results are now available to you to guide her dose. Lab results show that KZA has a CYP2C9*3*3 variant allele and a VKORC1G/A genotype. So my question to you is, which of the statements listed below best interprets KZA's likely sensitivity to warfarin? Is it A. Warfarin is contraindicated in this patient, or B. Variants in CYP2C9 and VKORC1 are irrelevant to warfarin, or C. Patient has higher sensitivity to warfarin, or is it D. Patient has a usual expected sensitivity to warfarin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Patient has higher sensitivity to warfarin. Answer C is correct. Available data analyses on pharmacogenetics and dose response show that patients with a VKORC1G/A genotype and CYP2C9*3*3 genotype are likely to have higher sensitivity to warfarin and thus require a lower than expected warfarin dose. Answer D is incorrect because this patient's genotype information suggests she will not have a usual expected sensitivity to warfarin. Answer B is incorrect because significant literature supports the relevance of CYP2C9 and VKORC1 genotypes and warfarin sensitivity. Answer A is incorrect because warfarin is not contraindicated in this patient, given the information provided. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which is part 201.